But today we're launching the webinars with Dr. Charlie Camosy. Charlie is Associate Professor of Theological and Social Ethics at Fordham University. He's very active as a writer, speaker, and social media presence on a range of issues. But from the very start of his writing, he has been really focused and engaged in this issue of the rationing of healthcare during crises. His first book he did was on that topic, and his newest book that many of you are aware of is Resisting Throwaway Culture, and includes a number of chapters dealing with healthcare related issues, as he's going to share with us. And he's really plunged himself into the middle of key debates raging across the country right now about how we can best respond to this pandemic consistent with our ethics. So with that, I'm going to hand it over to Charlie, and I'll say that as you're listening, if you have questions, you can click down in the Q&A box at the bottom of your Zoom screen, and you can share questions, and after Charlie's presentation, I will come back on and present some of those questions to Charlie for his response. So please do use that feature if you have any questions, and now it's over to Charlie.
As a professor who's tried to move his classes online, I'm increasingly familiar with this technology, but it doesn't always work exactly the way I hope. So if some of the things I'm sharing with you aren't coming through the way I'm intending them, I hope somebody will let me know. We can try to get that fixed. First of all, I just want to thank New City Press and Living City Magazine for inviting me. I care very deeply about the focal area movement and these two particular aspects of it, and feel very grateful to be a part of this. I'm going to go for about 15 or 20 minutes, just setting up what I hope to be an actual dialogue that would be fitting for a focal area sponsored event. So please do ask your questions. I'm going to try to only go for about 15 or 20 minutes. And how I would like to use that time will be, let's see, I want to do three things. I want to say something about, for lack of a better way of saying it, my background assumptions and worries coming into the conversations about what we've been thinking about when it comes to triage or rationing healthcare at this moment. Second, I want to highlight some of the responses to those worries that have come through, and I've been a part of some of them, but not anywhere close to all of them. But I do want to focus in particular on one common document I helped get off the ground, and maybe highlight some of the things about that. We can have some discussion. And then finally, I want to, assuming we have the time, I want to express some thoughts about an aspect of throwaway culture working here that we don't often think about, or that I think is not thought about and discussed openly enough. And that's the fact that yes, there's an absolute right, regardless of age and disability, to die in the ICU or be treated in the ICU if that's what you want. But if one wants to die at home, I think that's something that we ought to be thinking about very intentionally and carefully and expeditiously as well as we can as well. So those are the hopes I have for my part of this. But again, I'm looking forward to your part of it. So please do ask your questions. So background assumptions and worries that I'm bringing to this conversation. The first one comes right out of my dissertation and first book, which was titled Too Expensive to Treat, and really thought about Catholic social teaching and use of scarce healthcare resources. It did it mostly at the macro level, thinking about systems rather than individual triage situations, though I do talk extensively about those as kind of setting up the questions for the system level discussions. But I thought I'd just share one really important background assumption I have in this, and it's a theological one, or at least it comes out of a theological one, and that's we're finite creatures, and we are not only finite creatures, we have finite resources. And because we have virtually unlimited healthcare needs given our finitude and limited resources, we are going to be rationing care. We'll never not be rationing care. We don't have enough resources to meet everyone's healthcare needs. And so I think it's important to start there. Most of the time we're doing some rationing, all the time actually we're doing rationing at the systems level. It's rare we are confronted with it as directly as we have been in recent weeks and months, however. And even though we've avoided a lot of the stuff that I think many of us thought was coming, at least for now we've avoided it, like rationing of ventilators and ICU beds, we still have been doing some important rationing and triage in a certain sense. For instance, as you may know, in many places and in New York City, for instance, they've put what they've called non-essential medical interventions on hold and asked people not to engage those because they want to ration the care for those who are affected by COVID-19. But if you've been following the news, it's very bizarre actually calling these things non-essential. Even certain kinds of cancer treatments or even life-saving organ transplants have been deemed non-essential. Interestingly enough, abortion has not been put into that category. And a second example I just give is we've basically ignored nursing homes, and that's been a big problem, in part because we just had to focus on hospitals. And we're now starting to turn our attention to nursing homes in specific ways, but that's also one very direct way very clear way we've decided to ration our limited healthcare at the moment. But it could have been a lot worse, at least in this first wave. And thankfully, we've avoided some of the major things that people were worried about. Second background assumption and worry, I think it's super important to highlight what I wrote about in my most recent book with New City Press, Throwaway Culture. I've already mentioned that once, but especially in this context, I think it's important to talk about it with respect to how we think about the disabled and the elderly. There was already a strong throwaway culture with regard to these populations before the COVID-19 pandemic, but especially now that given that the throwaway culture has shaped our imaginations about who is valuable and who is deserving, it's just inconvenient now for us to kind of rethink those assumptions at this moment. Even though I think people do have some hesitations, many people have some hesitations about rationing care with regard to the disabled and elderly. It's kind of baked into our cultural cake at the moment, and so we need to unlearn some things in order to address that. So that's another assumption worry I have. Finally, a third assumption worry I bring to this comes from my background in medical ethics. I'm trained as a bioethicist, and I know very well the assumptions and frameworks that guide secular medicine and secular medical ethics when it comes to these questions. It's a bit of a assumption, or I don't know, stereotype, but it's true, broadly speaking, in my experience, that science-minded people often struggle with ethics because it doesn't have all the answers ready to solve using a systematic methodology the way that they're used to with more science or medically minded methodology. So, I often get science-minded people in my ethics classes or coming to my ethics talks saying, well, what's the right answer? Tell me how to get to the right answer. And of course, I'm not going to be able to give them that kind of methodology to arrive at a right answer. However, there is one kind of school or broadly understood school of ethics that kind of approaches this methodology, and that's utilitarianism. So producing the greatest good for the greatest number, especially if one imagines this like a math problem or a proof of some kind, or a theoretical thing that can be unpacked and advanced via a calculation of some kind. That is attractive to many for multiple reasons, attractive to many in secular medicine and secular medical ethics in particular. And that has risen to the fore at this moment. In fact, some places just assume, even highly rated medical schools and medical centers will just assume that if you're going to talk about pandemic ethics, you're talking about some version of utilitarianism. And there really aren't other schools that are important to engage. One typical way this is done is to think about added life years to a medical intervention. So you think, well, should we give the ventilator to this person or that person? Well, the answer is to add up how many life years you could add to the various people's lives and pick the one that will add the most life years. And if that sounds ageist and a violation of civil rights, that's because it is ageist and a violation of civil rights. But it is at the heart of a lot of fairly typical secular clinical ethics and ethics reasoning more generally, at least those that are dominant in those spaces. Almost as popular is a version of adding life years that has become known as QALYs or QALYs. Quality adjusted life years is absolutely dominant in many ways of thinking about ethics. So we're not going to just think about how many life years could we add if we give a ventilator to this person for that person, but we're going to actually multiply by a particular coefficient that will rate the person's quality of life on a scale of 0 to 1. So if one is going to have a perfectly flourishing life with regard to its quality, whatever that means, you multiply by 1. So if you added 10 years, multiply 1, you get 10 years. But if in the judgment of the person making the calculation, the quality of life is half of what it would normally be, then you'd multiply by 0.5. So 10 regular life years would be 5 quality adjusted life years. Now, don't ask me how we come to judgments about individuals' quality of life, especially from people who tend to rate, especially physicians are really bad at rating the quality of life of their patients. They often rate, in fact, the quality of life of their patients lower than the patients do themselves. But if that sounds like a kind of ableism, that's because it is. It's very much coming from, again, this culture of a throwaway culture where consumerism defines how we're valued. Okay, so let's think about a little bit about how these background worries, at least from my perspective, have played out in recent weeks and months. So most of these conversations are quite academic without a lot of public scrutiny. I think that's important to mention right up front. And when we're thinking about how to ration care, the one thing that most medical ethics can agree on, medical ethicists can agree on, is that there ought to be some sort of public-facing aspect to what a hospital or state or medical system decides to do. It ought to be transparent. But I was very interested to learn that one of the earliest articles to come out on rationing healthcare, and here I am going to try to share my first screen with you. Let's see if I can do this right. Share. Okay, so this, if it's working, is a article from the New England Journal of Medicine. And it's from about a month ago. And it's thinking about how COVID-19 in Italy was fought, and thinking about, in particular, how rationing of care was going on in Italy. And it's an interesting article. It has lots of things going on, but I found this line very interesting in light of what I just talked about. The author says, rationing is often better tolerated when done silently. And that's true, because a number of, a very high percentage of people in the public don't agree with quality adjusted life years as being the metric by which we will judge what's valuable and even how to think about how to ration scarce resources. But this is an article in the New England Journal of Medicine pointing out, now to be fair, it doesn't argue for this, but it is pointing it out for a reason. And that's because a lot of, even though medical ethicists agree that it should be transparent, a lot of the rationing does take place on the down low without public facing or transparent protocols. And we still don't know how a lot of hospitals and medical systems in states have decided to go about doing this, though there has been some increased sense of this, of public facing aspects of this going forward. Now, here's another important New England Journal of Medicine piece that I thought I'd highlight. The first author of which is Ezekiel Emanuel, who is one of the main architects of the Affordable Care Act. He wrote this piece specifically to give advice, a framework for thinking about how to ration healthcare. And there's, again, lots of stuff here, but I think I want to highlight a couple things about this. Recommendation 1 is that in the case of the pandemic, the value of maximizing benefits is most important. It just assumes that. It cites some, obviously you can cite almost anything in support, or you can find cites for almost any position in ethics if you want. That is a contested claim, but it's not contested in the world of Ezekiel Emanuel. And then going on, you'll find that what it means to maximize benefits involves not only saving more lives, but more life, more years of life. And then they call that a consensus value. Well, of course, it's a value, but the idea that, again, that quality adjusted is not here, but adding more years of life as a primary consideration is definitely here, especially when maximizing benefits is defined this way. and maximizing benefits is deemed as the most important. The question of justice, and especially social justice for the most vulnerable, is relegated to a secondary consideration. Now, this is, again, only years of life that's being discussed. It doesn't talk about quality adjusted life years, but then the disability rights community has been communities have been very active in being very skeptical of what they have seen from certain quarters, and even certain, this is from the Seattle Times, in the area of one of the first major outbreaks of COVID-19, they really gave it to the folks that they were seeing coming from their state when it came to this. In fact, the existing state guidance for triage teams recommends considering transferring hospital patients with, quote, loss of reserves and energy, physical ability, cognition, and general health to outpatient or palliative care. You don't get more directly ableist than that. In fact, it even talks about ability, physical ability and cognition as direct factors to take into direct consideration when it comes to that. Now, happily, there have been some major responses that have been put forth to resist this. And I want to highlight some of those at this time. Here is a press release from the Thomas More Society, a legal society, which did, in conversation with some of their legal partners and firms that they're in partnership with, did a legal analysis of some of these practices and found that they were actually in direct violation of the civil rights law in the United States. So even under pandemic conditions, these kind of civil rights should be respected. Let's see if I can find this. In addition to that, the Office of Civil Rights at HHS, let me go back to the recommendation here. It finishes by saying, disability and age should not be used as categorical exclusion in making critical decisions. And if that seems at all counterintuitive to you, you should know that the state of New York's guidelines for ventilator protocol, which came about, this is a document from 2015, specifically says advanced age was rejected as a triage criterion because it discriminates against the elderly, and notes that age already factors into criteria that assess the overall health of the patient, which they argue, and also the Thomas More Society argues, should be the only concern by which we allocate scarce healthcare resources. Will this, first does the patient have the need, a dramatic need in a way that calls for the care, and then how likely are they to benefit from the care? Those are the ways that New York has said we ought to allocate this, but it goes in direct contradiction to what I've already been suggesting to you. Happily, the Office of Civil Rights at the Office of Health and Human Services, the Federal Health and Human Services Office, issued a bulletin saying that civil rights still apply in our current pandemic moment. And they want to focus on ensuring that anybody that gets federal aid is not unlawfully discriminating on the basis of age or ability in particular. And as a result of that, that caused some consternation among certain places like Washington, but also Alabama. Alabama had a policy that explicitly discriminated on the basis of what I believed they called the profound mental retardation, moderate severe dementia. And that was obviously found deeply problematic. And happily, the Office of Civil Rights closed its compliance review and investigation over ventilator triage in Alabama because they changed their policy. So that was a happy result. Another kind of response that happened was this common document that was a joint statement of moral guidance on prioritizing care during a pandemic. I reached out to Professor Robert George at Princeton, and we came up with a first draft of this together. But all the signatories, who are listed here, had their crack at it too. So it was, here's Cornel West, one of his major interlocutors who thinks differently from about a lot of issues. He was a signatory as well. After the other signatories got their, sometimes more than 2 cents here, it became a very different kind of document. But I think it's worth engaging. I'll just highlight a couple things. First, allowed casualties are not intentional killings. Again, if we're going to be true to ourselves and what our finite natures and our finite resources, we are always choosing to not treat certain people and treat others, either by the systems level or in this case, in a triage situation. But the choice not to kill or not to aid is not a choice to kill. The second value here, or the second part here that's important to highlight, I've already highlighted an important part of this, is that human lives are all of equal value. That it hopefully doesn't need a whole lot of explanation at this point, but here is a part I'd like to highlight. And one way that this document went through multiple iterations was we didn't actually all agree on how to express our concern about the life years approach. However, it says we did all share a concern that the life years approach, even if used only as a secondary consideration, could come to be understood in ways that would cut against the claims of the elderly, the disabled, and those who seem to have little to contribute. So at least we all agree that the practical effects of this were really possibly damaging, especially, they don't use the term throwaway culture, but especially in terms of our throwaway culture. Here, the language is used. That depends in part on what our culture has already primed us to think. And ours is a culture in which youth is worshipped and the natural effects of age are despised. Sometimes we fall into patterns of thinking of the elderly as a burden on themselves and on us. So that's, I think, a very important thing to think here about as well, is what sort of practical effects does this reasoning have, especially when we're already hyper-focused on things like age and productivity and ability and consumerism in terms of our, to use a fancy word, moral anthropology, or what we think of as valuable about the human person. All right, let's see where I am with time. That is probably about 20 minutes. I do want to at least highlight a final point that I said I was going to bring up here, which is an aspect of throwaway culture which we don't talk about very often, and that this was my Religion News Service column. It came out yesterday. We need to respect the choice to not die of COVID-19 alone. 70% of U.S. Americans want to die at home accompanied by loved ones, but 68% don't get that kind of death. This is before COVID-19. And one of the, of course, really difficult and even horrific things about this, the way people are dying of COVID-19, is that they are not only dying in the ICU, but they're dying apart from their friends and family, often without even being able to say goodbye. And I argue in this piece that part of a way that throwaway culture is working right now, in ways that are just not at all helpful and even terrible, is that we're pushing people in the ICU to go to the ICU, emergency room and then ICU. When I think many of them, if they were pressed, would say, I would just prefer to get home healthcare and hospice if that's what's necessary. My thinking about this started when a colleague of mine in medical ethics wrote me to say that she was thinking about her 90-year-old mother, who's in very good health, but who, if she were to go through the ICU experience and especially getting intubated, that she would die there and likely die alone, and that her mother would want to stay home, and that she would want to stay home with her mother. And so I think it's right to call that a kind of throwaway culture, to say, yeah, it's really difficult to think about how we're going to manage situations where people want to die at home with COVID-19. It would take a lot of work, a lot of ramping up, a lot of PPE, personal protective equipment, for people who work in home hospice, for priests and other ministers who are administering last rites and for the family themselves, and we need trained, qualified people to ramp up in these regards. But this is what we did for ICU care already, and we're still continuing to do it. And in the piece, I argue that we ought to, if we really want to respect the dignity of all who are in a situation that they don't want to be in with this virus, yes, they have a civil right to go to the ICU if that's what they want. But if they want to die at home, we should actually be working just as hard to give them the resources to do that. And I could talk more about that if you'd like, but I think I promised I'd make room for this robust discussion. I think I'll just leave it there.
So Charlie, you hear me?
Yeah, I can hear you.
Okay, great. So we've had some really good questions come in, and in fact, maybe we'll start with the one just related to what you were just talking about now.
Mm-hmm.
So someone was asking about that question of hospice issues for people who either don't need ICU or like you said, want to die at home. I'm just wondering if you've seen any examples of that playing out nationally yet, or if you had any responses from your article yesterday from practitioners.
I have not got a reaction yet from. Let me stop sharing. Or should I keep sharing my screen here? I have not got reactions from practitioners yet from the article that was published yesterday, but this article was actually scheduled to be published in the New York Times on Wednesday, and a long, complicated story. It didn't, and they asked me to do a significant amount of reporting for this piece. And I talked with a number of practitioners, including the head of a national organization for home health care and home hospice. And the answer is they're already doing this. But part of the answer is that they just don't have the resources to meet the needs. Even if we were, which we aren't, encouraging people who would prefer to stay home and get home hospice, there aren't the resources to do it right now. And so they're trying to gear up. They're trying to get home healthcare providers and home hospice providers the necessary PPE and the necessary staff to meet the need, especially if we ever did decide to make this a priority as a culture during this time. But so that's the, I guess the short answer is they're already doing it in certain cases, but there isn't enough resources to do it for everyone who would want it.
Yeah. So one of the things we'll do, Charlie, I think someone was asking about sharing some of these links that you have with folks. So we'll be sure, I think in the email we send to you after the webinar, we'll include some of these links.
Sure.
And in that, I'll just mention, we have an author who is a chaplain and is a part of the Catholic Chaplain Network, who's written a book for us that came out on life and death issues that just came out. And I mentioned that because we will send an article that he just did about looking at this kind of from the perspective of chaplains, and also send you all a link to the Catholic Chaplain Ministry Association. They're doing a lot of stuff online and trying to help their membership during this time of crisis and ministry. Charlie, a question that came up was also if you could just say a little bit more about maximizing benefits, just kind of what you mean by that expression and how it's used by people.
Yeah, so just going back to the Ezekiel Emanuel piece, secular clinical bioethics is dominated by something called principlism, which is a very simplistic way of thinking about bioethics that tries to balance four principles: autonomy, beneficence, non-maleficence, and justice. And you can see how, for those of us that know the field, you can see how principlism is being talked about here. Even up here, it talks about the ethical values being maximizing benefits, treating equally, promoting and rewarding institutional value, and giving priority to the worst off. Which this is interesting. This would be a justice consideration, especially a social justice consideration, especially in it, but not only in a Catholic context. Preferential option for the vulnerable or the poor. But in a pandemic situation, it's often thought about as this is a typical kind of response as well. Everything changes during a pandemic. We reason more like utilitarians, and that's what this article has in mind here. Maximizing benefits again thinks about saving more lives and adding more years of life at the center of that. My view is that it's way more complicated than this. It doesn't make sense to say the value of maximizing benefits is the most important, because if that were true, then we could do all sorts of things that would violate the civil rights of people to maximize benefits. Maybe we'd round up every 10th person and just inject them with COVID-19 and see what kind of clinical results we could get to maximize benefits. Of course, we won't do that because justice questions rightly prohibit us from ever doing something like that. So maximizing benefits there could mean lots of different things, but in this context, it means something like, again, saving more lives or adding more years of life. And it doesn't mean respecting rights or respecting the justice considerations, what people are owed. And it certainly doesn't mean what people generally mean by social justice, which is thinking in particular about those who our culture is left behind and who are most at risk, especially in light of throwaway culture.
So Charlie, a couple questions that are kind of building off this last point about the in-home care option and stuff. Is one of them is just kind of a question that I think I know you've touched on the article. Maybe you can mention, is just that question of spreading the virus, at home, and how you would weigh that element. And then I think there's also a question that maybe you can respond to that's just a concern about the costs of that and the challenge of providing that kind of care at home, and in terms of if there are real ICU needs like ventilators and things like that. So if you could maybe just flesh that out a little bit for us, that'd be great.
Sure. Well, I hope it's not cheating to say read the article, but I spend a number of lines trying to address both those questions. So, for instance, you're not going to have ventilation in a home hospice situation, but home hospice staff are really practiced at helping patients who have these problems already. They know how to use the right amount of morphine and concentrated oxygen to relieve the need to gasp for air, and using muscle relaxants and often anti-anxiety medications to put patients at ease. They're very, very skilled in addressing precisely these kinds of situations. But as I mentioned already and talk about here, we just don't currently have enough resources for those who would want that kind of expert care. There's no reason in principle we couldn't have the resources for it, though, because to address one of the questions directly that you mentioned, it's wildly more expensive to get somebody ICU care in a hospital than it would be to do this kind of care. It's not cheap, of course, to do this kind of care, but it's way, way, way less expensive than ICU care. Now, one of the things that the New York Times wanted me to report on, because they had the same question about higher rates of infection. And I had a conversation with the CEO of the National Hospice and Palliative Care Association, and he said a couple of interesting things. He said, first of all, it's actually documented in Italy that people who got home health care actually did better than those that went to the hospital, at least in that northern part of Italy there, in part because the hospitals were such, well, if you didn't have COVID-19 and you were having these symptoms, you had COVID-19 after you went to the hospital. So if you were actually treated at home and it turns out you didn't have COVID-19, they had much better outcomes. But then I asked him about this increased level of exposure for the family. And I did a lot of research and reporting for this, and it's complicated. If the patient is isolated in the house, then having a situation where the family gets to say goodbye, even in situations that are very controlled, could modestly increase the chances of infection. However, if the family has not been isolating and just taking care of their family member in a very close level, it's probably not going to raise the level of risk of infection very much at all. But Bannock said, the guy I interviewed for this said, suppose the risk level does get raised a small percentage. This has to be weighed against the very good chance of dropping a loved one off at the hospital and they're dying without ever being able to say goodbye. That's a very personal decision for that family, for those family members, and they ought to be able to make it. And that's how I finish the piece. Even if what if they and their family members prefer a communal death, which should be one of the highest values I think we can imagine there being. I argue that even if it marginally increases the chance of infection, this is something we should not only permit, but encourage. Again, I've been one of the most outspoken people for people who want it to get ICU care, especially if they're a vulnerable population like the elderly or the young, or if they have disability of some kind. But if they want to stay and get treated at home and perhaps die at home, then I think that's the kind of thing we should wrestle with.
Thank you. So Charlie, an early question that came in was related to kind of the question of, has it been a lack of resources, or this questioner was asking if it's also related to just an overall lack of planning and a lack of kind of value for public health that we had coming into this. I don't know if you want to reflect on some of those pieces.
Well, if the numbers that we were originally given about who would be infected and how many people would need ICU beds and ventilators were correct, it'd be difficult to know how virtually any kind of planning would have been sufficient to meet the needs. Even if you could say we're going to stockpile ventilators or something like that, the gargantuan needs that we would have had if the original numbers were correct for just actual staff who are capable of operating a ventilator and intubating somebody are so humongous. I mean, New York, as you probably know, we're just trying to scrounge around for anyone around the country. Please come to New York. We're not going to have enough people to do this. We will pay you, and we will come back to your state when you need it, and all that. So yes, I mean, the answer is if we had not gotten rid of certain kinds of stockpiles of especially personal protective equipment and ventilators and oxygen and other things, we would have been in a better situation. But how do you get, specialists who know how to operate ventilators on reserve? There is no national stockpile of people like that. And it's hard to imagine what that would even look like.
Right. So question about how you're seeing this. Someone writes in about how you're seeing this discussed within the media, and whether or not you're seeing aspects of throwaway culture coming into how this is being discussed. Obviously, it's a huge, the media in general is a huge topic, but if you might touch some on how you're seeing media use language and reflection within that.
Yeah, to be honest, I've been really disappointed, not in what the media has said about this, but what they haven't said, and like how little was talked about. This was talked about, even when the numbers seemed to be such that this was virtually unavoidable. There were so much coverage of this, wall-to-wall coverage all day long, but we should have been having discussions about quality adjusted life years versus justice approaches. That should have been at the heart of many different kinds of conversations. And we should have had discussions about how transparent hospitals should be, about who is making these decisions, on what basis are they making the protocols, how many voices, what kinds of voices are present at the table when the protocols for individual hospitals are being made, or especially when they're being made at the state level. But aside from a few articles that I've shared with you and maybe a handful of others, that really wasn't at the heart of the coverage at all. And even when even when especially public figures were pressed on it at certain times, like Cuomo was pressed on it a few times, Governor Cuomo of New York, again, at times where given the numbers we were getting from the projected models, we're like, this is coming and there's no way to avoid it, at least if those numbers were correct. He just refused to answer the question when he was asked, what are you going to do? What's the protocol? And so I think we missed out actually on a chance to have these discussions, or at least in a preliminary sense, we missed out. Maybe, especially if there's as some are predicting, a second wave coming in the fall, we ought to spend the summer having more robust and deep discussions about these kinds of questions, especially those questions about who is at the table and who is involved and what methodologies are being employed to decide these things, and are they public or are they transparent or are they not? Are they, as the first article mentioned, are they being done on the down low or being kind of silent in this? So I think we missed an opportunity to have these discussions in the first part, but God forbid there's a second part. But in case there is, especially, but not only, we ought to maybe take some more time to think about this.
Yeah, I think I remember in some of your reporting, you had a couple of different major hospital administrators. I think, was it Houston maybe? Some other places where you did have people on the record speaking about this in ways that were, I think, kind of disconcerting to you.
Yeah, I saw the American Society of Bioethics and Humanities put out a treasure trove, essentially, of resources about these questions a few weeks ago, and there was the draft protocol from a hospital in Houston, which explicitly invoked life years and ableist views about quality of life. As I mentioned earlier, Seattle or Washington State had a protocol that was accepted, which explicitly took into account those kind of ableist considerations as well. They had a conference call with about 300 clinicians where they decided, at least provisionally, to have an age cutoff for ventilators. So, at this point, I'm not totally sure how many have decided on what they are, but I think we need that robust discussion.
Yeah. Can we maybe go back a little bit to the home palliative care option? I'm seeing a number of questions. I think it's probably some folks that are in the profession as well. Just to try to touch on some of the issues for. I think some folks may be having a hard time picturing how that might work, but maybe, because I think, when I've read your article, maybe you could say a little bit more about the distinction of level of care that you're imagining might be happening at home versus not happening at home, and stages of that care, to address some of those.
Yeah, so I'm not exactly sure what the question is, but I can speak broadly about what I've learned from my research and talking to clinicians about this. And that's that, well, first of all, we're learning that intubation and ventilation often doesn't help. It may keep people alive for a short time, but it ultimately does not help a lot of patients, and sometimes can actually do more damage than if they weren't ventilated at all, which is one reason I think why patients in Italy did 50% better if they were treated at home versus if they were treated in the Italian ICU. But if the question is, can they get the same level of ICU care at home? Of course not. They can't get that level of care.
Yeah, and I think you also, there's a couple questions just related. One of the folks is asking, she works in home healthcare, healthcare aides, and some of the challenges that they're facing. Do you mind speaking to some of the, I know you've spoken to people on the front lines. Could you share a little bit of what you're hearing from people and what just some of those real poignant challenges that folks are having on the front line.
You mean in home healthcare or more
I
broadly?
guess more broadly too. Yeah.
Yeah. Well, I mean, we weren't ready for this when it comes to personal protective equipment, in particular for our providers in the front lines. And so there's been some heroic is a word that's thrown around a lot, but it really doesn't describe what, everyone from nursing techs to attending physicians have been doing on the front lines of this, putting themselves at serious risk. And another thing I think is worth pointing out about, the difference between ICU care and home health care in these situations is, intubation and also resuscitation put the clinical staff and the medical team at tremendous risk for infection in ways that home health care really doesn't. There's of course risk at home too. I'm not saying there is no risk, but it's really dramatic for these providers, especially in the ICU and in the ER. And so that's one really important and significant problem that's facing so many practitioners on the front lines is they just don't have the personal protective equipment that they need. That's gotten better in the last couple of weeks, especially, but especially at the beginning, it was really touch and go. It is particularly bad in nursing homes, and it is particularly bad still with home health care. That's one of the things that I talked about in my piece, where I talked about, let's see, if I can find the actual link. Yeah, here's a piece from Health Affairs where they're talking about this is a piece by Dr. Joanne Lynn, who I had some conversations with. She's a geriatrician and palliative care physician, who said, we're already doing this, we're already treating COVID patients, but we need to ramp up and do better and get more resources. And so they're not there yet, especially with personal protective equipment. But we weren't there yet either with regard to ICU care. And we've made really dramatic increases in getting the frontline people in ERs and ICUs the resources they need, especially if we're going to take, these kind of folks seriously, who say we ought to help people who want to die at home have the resources to do that. We got to have a similar level of urgency and energy and creative thinking, frankly, so that patients who are in those situations have what they need there too, and healthcare providers in those situations have what they need too.
Charlie, I'm wondering, your phrase, the framework of throwaway culture, is related to language that Pope Francis has used. And then I think last week he again used that language in an interview that he gave, and also talks about the great benefits of the elderly to us. I'm wondering if you could just speak to your kind of connection to Pope Francis's teaching on that, and just give us maybe an update based on some of the things he's talked about real recently.
Well, you may have something in mind about that I don't, but yeah, as you mentioned, the elderly as a particularly as a paradigmatic example of a classic victim of throwaway culture, he's been outspoken with regard to in many ways. And in particular, because it comes straight out of his linking throwaway culture to consumerism, and consumerism as being the kind of framework or eye through which we look at what we value in human beings. One of my favorite bioethicists of all time, Gilbert Mylander, wrote an article one time, the title of which was, "I hope to one day be a burden on my family." And the way that headline subverted the way we normally think of what makes it funny is it totally flips the kind of cultural expectations that come from a consumerist throwaway culture, where of course being a burden is bad, or what's being described as being a burden is bad. But what Mailander is doing in that article is flipping that notion on its head in ways that Pope Francis would surely appreciate, and say, not only is that the wrong way to think about it, we should be giving them special consideration and special care and treatment. So when the Ezekiel Emanuel talks about giving priority to the worst off, that's where I want to start. That's where, especially as somebody who's a committed Catholic and student of Catholic social teaching, I want to start with the principle of giving priority to the worst off, instead of maximizing benefits is important, but it's not the most important. And one thing that I think is really super important to highlight here is giving priority to the worst off is, especially in a social justice context today, what so many talking heads on television are about in other contexts. And that's another thing I was really disappointed that I didn't see happening in the discussion of these questions publicly in the media, was where are the people who normally talk about these things? Where were they in the public discussions about who gets a ventilator and who doesn't? I didn't see them represented at all. Now, maybe that's decisions made by producers, or maybe it's not clear exactly, again, how that happens. But if one is going to, surely if one takes Pope Francis's approach, giving priority to the worst off means a special consideration for our elderly.
Yeah, thank you. Maybe one last question. Good with one more?
Sure.
Okay, so this one kind of raises issues of principalism, and I think you guys pronounce it Kali, Q-A-L-Y aspect of the discussion.
I've heard Quayle, I've heard Quali.
Okay.
Yeah, it doesn't matter.
Okay, yeah. Just wondering, there was a question that kind of asked you to address those, if you could.
Well, I mean, I'm not sure what it means by address. The principalism framework tends to respect patient autonomy. Well, it depends who's using the framework, obviously. Like the framework, if you just have 4 principles, autonomy, beneficence, non-maleficence, and justice, then it really depends on the person and their own particular point of view. That's why I don't think principalism is a helpful framework, because one's particular vision of the good can just be read into it in ways that it's not really a helpful framework. So you can have somebody who's more utilitarian minded and one's more social justice minded use principalism to arrive at whatever position they want. In the pandemic situation, the same folks who would normally prioritize autonomy say we need to maximize benefits as being most important. And that's where the influence of Quayle or Quali utilitarian-minded folks tend to raise their point of view and tend to be most influential. I mean, I think a key point here is in the context of a pandemic, because again, with principalism, autonomy tends to rule the day. Well, a certain vision of autonomy tends to rule the day. I don't know if that's what the questioner had in mind, but that was my best attempt at trying to think about those two together.
Yeah, no, I think that was, I think he was at a similar view and was, just kind of wanting to see you try to express that. Thank you.
Sure.
So I think we're getting close to wrapping up, and I think we want to make sure to let you know that if there's some unanswered questions or some issues that we weren't quite able to get with, Charlie, if you could just share your Twitter handle. I know you are real active there. If folks want to follow up, is that a good way?
Yeah, sure. So it's just at Camosy, CCAMOSY, or they can just send me a good old fashioned email, ccamosy@gmail.com too.
Okay, great. Thanks. And then a reminder that we will be having on Facebook Live, 2 p.m. Eastern on Thursday, we're going to have an event with Jimmy Walters, author of a new book, Dreams Come True. He's going to be talking about how we can continue to dream, continue to have goals even in the midst of this crisis. and thinking about what those deeper dreams can be meaning for us in terms of reaching out to others and caring for others. But I think we just really want to say thank you, Charlie. We really appreciate your time, appreciate your work, and this was a really great start to what we're doing. And we will send follow-up emails to everyone with some of these links and with some other resources. But for now, thanks so much to everyone for being a part of our first webinar. Take care.